mention that one of the speakers, Dr. Lee Hill, is regrettably unable to attend. He and his partner just welcomed their second baby, literally yesterday. And it was a little earlier than planned. So we extend our warm congratulations to him and his family. And it is finally my pleasure to introduce to you our speakers, Dr. Esli Osmanlliu, assistant professor at McGill University and junior scientist at CORE here, and Annie-Danielle Grenier, a rare disease advocate and patient partner. Thank you so much.
Thank you so much, Katia, for the introductions. My colleague Annie-Danielle Grenier is online. Annie-Danielle, are you able to say hi to the group? There we go. It's a pleasure to see you here today, talking about patient engagement. So we're holding the fort. I'm even surprised that Lee is still answering emails. Hope they enjoyed that precious time with the family. So today we'll be talking about untapped expertise, how patient partners can enhance your projects. Yeah. So in terms of the plan for today, we'll talk first about patient, family, and public engagement in research, about some theoretical concepts. Then engagement and health AI, using the Marvin and Champ health chatbots as a use case to describe some opportunities in health AI and digital health research. And then my colleague Annie-Danielle Grenier will talk about her own experience from patient to PI, from patient partner to experiences and tips for successful engagement. This was the positionality and disclosure slides for Lee and his team. So nothing to disclose on my end, nothing to disclose either. I've put some research funding on the slide that I benefit from. In terms of land acknowledgement, we wanted to acknowledge that the land on which we're gathering is traditional ceded territory of the Mohawk people, a place which has long served as a site of meeting and exchange amongst nations. Because we'll be talking a little bit also about indigenous wisdom in this talk. And you've seen land acknowledgements probably for quite a few years. They have a place, they have value. But I often find that when it limits itself to a slide, the reach itself is limited. And personally, an experience that was quite striking was at an event called Les Autochtoneries du Théâtre des Écuries in April 2024, where multidisciplinary artist Jacques Nawashish, an Atikamekw artist, was actually, before the play, was conducting a live contemporary art activity. And at the end of it, took a pair of scissors and started this huge canvas and started cutting through the canvas. And the crowd was a bit stabilized by that action. And then he went on to explain that gesture represented how the territory, the unceded territory of Indigenous people, has been compartmentalized and for private interest. And through an act of really powerful generosity, he was giving pieces of the territory back to the members of the audience, asking us as custodians to take care of that territory. I found that was quite a powerful land acknowledgement in our collective and individual responsibility to take care of that land. And you may have also heard about the principles of 7 generations impacts, right? When we're doing an intervention, us all as health researchers, what will be the impact not only in our patient cohort, but in 7 generations? How many of us think of that? I don't. I wish I did more, but that's Indigenous wisdom as well, that's so precious to integrate into our practice. Here. So we'll be talking about patient and public engagement. And sorry, I have the light here. So as a warmer, as a little warm up, there's a list of objects on the slide, and I'd like to know, those of you that perhaps include patients, members of the public in your research, does any of those objects stand out as representing engagement in research? Any objects that to you says, oh yeah, the bagel, the scissors, the urn, the dispill? Does anything stand out to you as evoking patient and public engagement in research? Is it okay on the mic? For online, we're doing okay on the mic? Yeah. Perfect. Any takers? You can get an extra cookie if you get the right answer. Red teapot? Is that Annie-Danielle or somebody else on Sonia Lussier? Okay, well, Sonia, maybe we'll be able to provide some more explanation there if she wants to speak up. But otherwise, anybody else? Yes. Yes. The
It
VHS.
could be like recordings from people's lives or these types of things that could give you an insight into their lives, right? Or
It's a narrative, stories.
Yes, narratives, exactly.
Yes, absolutely.
Yes.
Very powerful. Yeah. Yes. Oh, right there.
Eyes. Yeah.
Uh-huh.
I was just thinking maybe like because the eyes are having different emotions, like different emotions that patients go through. Yeah.
Absolutely. So it's diverse in perspectives and emotions and what's been going on in your day. Absolutely.
Yeah.
And you'll see in the next couple slides, it seems like those answers were planted, but they weren't. But absolutely aligned with what I'm about to share next. Anybody else? Any objects that stand out to you?
Food.
Food. Yes.
Food,
Why?
Yes. The richest conversations happened at the lunch table.
Just like today, right?
Yes.
Absolutely. Thank you. I'm not sure if Sonia wanted to share why the red teapot. So I see you're on video, Sonia.
Yeah, sure. Actually, I wrote the bread. The bread because to make good partnership, you need good ingredients, and then you have to work at it. It's work, and then you put it all together and you amalgamate it, and then you get this wonderful results that's very tasteful.
So you're an excellent boulangère then.
My husband is.
Thanks, Sonia. So a personal experience, actually, as I was in my first steps in research as a trainee, I put actually the children's ER. I was a fellow at Saint-Justine then. I'm a pediatric emergency physician by training. And so in my fellowship, I was involved in a survey to assess patient experiences on a change in our care processes with asthmatic children. And so we were pilot testing the survey with some parents in the ER who were being treated for this condition. And frankly, mea culpa, it wasn't a reflex for me to go and pilot test it. It was like, we have the survey, we worked hard enough on it, let's just start. Thankfully, I had a mentor who was well-versed in patient engagement and research. And even at this very early steps that we absolutely need to pilot test it. And then I recognized the value of that through the experience, but not only the value, the generosity of people involved in research. So I went to see a family, asked if they would accept to spend some time with me. I was not involved in their care circle, so I came in as an external researcher. And so we sat down for a few minutes, went over the questionnaire. They provided really good insight. And at the end, so they're there with their son who had a asthma exacerbation, so was quite sick from a respiratory standpoint, having a hard time breathing. And then the other parent says, "Oh, I have to go to the NICU, so the neonatal ICU." Which I figured, why would you go in the NICU? Your son is here in the emerge. And they had another baby in the neonatal ICU who is getting 24/7 care for their premature delivery. And the parents were there. I'm not sure how much time they had to spend with one another with their older child with an asthma crisis, and accepted to spend 15 minutes providing insightful, rich comments for my questionnaire, which seemed so inconsequential when I realized what was going on in their lives. But yet I imagine they recognized the value in that exercise and shared really important feedback there. So I was very thankful. And it's kind of stayed with me as this has become an important pillar of my own research program over the years. And so that was, you see in the ICU, I mean, this is not a picture of their baby, obviously, but you see in the NICU, babies are quite monitored. It's a very high stress environment, and yet they accepted to spend time for research. And lived experiences is specifically in the ER, but applies to all other settings. We notice differences across access to care, education, health literacy, migration pathways, language, religion. There's a lot that sets us apart. There's also a lot that brings us together, shared desires and goals with respect to a child's health and well-being, the need for respect, building trust, access to care as well. So there's a lot of things that patient engagement, those narratives that you mentioned earlier, bring people around the table, sharing different perspectives, all the important ingredients and the hard work involved in patient engagement, they can allow for those precious interactions to happen. So there's a lot that also unites us. So what is patient family and public engagement? I'm not only putting patients as a pediatrician, it's important to recognize that patients are at the core of it, but their families, their caregivers, the whole public also, right, has a role and a place to play in research. So it's studying, developing, designing, evaluating with rather than for them. And it values and leverages experiential knowledge, what we've been talking about. And so it requires culture change and capacity building. And you can see the trajectory on the slide of a more paternalistic and then more of a patient-centric approach over the years to the goal of partnership within the care circle. So not about you, for you, but with you is the idea. And there's different ways of achieving that. That's an involvement matrix that I like as a conceptual framework to think about some of this. So on the y-axis, shall we say, you have these stages of a research project where patient engagement, public engagement can play a role. So early on in the preparation stages, during execution of a project, and also during implementation. So at every one of these stages, there's a role. Perhaps not every project will tick all those boxes, but think about what, ideally early in the project, what role and how can I leverage the power of those experiential knowledge sharings. Roles in specific projects can be as a listener, so somebody that's given information. And then as we go towards the right of this matrix, we're having higher forms of engagement. So as a co-thinker is asked to give an opinion, as an advisor gives solicited or unsolicited advice, as a partner works as an equal partner, and as a decision maker actually takes initiative and will have the final word in some cases. So that's a matrix that can be helpful in conceptualizing in your own projects. How can this play out? And this slide here also thinks a little bit more about the conceptualizing stages of research, study design, consultation, training, data collection, facilitation, co-interpretation, and then knowledge dissemination. And this is a cycle, right? These are cycles of collective learning that can be really precious and enrich your collective research projects. Any questions so far? Any experiences that you've had in your own work that you wanted to share with the group? So far, so good. And specifically, so these were, this was work that my colleagues were meant to present today. So Dr. Lee and colleagues wanted to share as they've done a lot of work, and I've also collaborated with Dr. Wissanji and his team on surgical initiatives that are done in partnership with Indigenous communities, particularly in James Bay. And some of the learning points that we've developed over the years are that, of course, we're navigating historical trauma, legitimate distrust of institutions, capacity constraints that don't exist in other research contexts. And that can make it at times frustrating, challenging, difficult. There's ethical questions that arise along the way, operational questions. But also the matter of time, it's not an obstacle to overcome quickly. At a Système de Santé Apprenant conference with Indigenous leaders, one of the concepts that they shared was the idea of the settlement, the camp, le campement, where when you go in and aim for partnership or collaboration with an Indigenous community, the idea is that you don't barge right in. You're actually sitting at the edge of the camp, waiting to understand the context, understand the place, the time, and eventually be welcomed in, which would be the prerogative of the people in the tent, in the camp, right? So that's the whole idea of sitting at the edge of the camp, waiting to be welcomed in, and showing some patience, showing some humility also in that experience. And I think that was a beautiful analogy to keep in mind, especially as we have sometimes time constraints, operational constraints that maybe don't quite well align with that timeline. But if we truly want to do it in a non-tokenistic way, it's something to consider, even in our planning, our timelines, our budget, right? So some learning points that we've had along the way in terms of time. So budget relationship building before the research begins. So building those relationships takes time, but is extremely precious and enriching. Plan for appropriate compensation for patient community partners. So we have guidelines from CFPPP. We have guidelines from Childbright here in pediatric and developmental research here at the Institute. Think about training. And so, for example, the Cree Health Board of and Social Services offers cultural sensitivity training for staff involved in research with their own experts, different levels of it. So I'd encourage you to look into that. There's, of course, OCAP principles that are developed by First Nations leaders, thinking about governance, sovereignty of the data, and building leadership also takes time. If it's truly valued in an institution, that concept of partnership, it will take some time, but it's totally worth it. So these were some slides by my colleagues at the Centre d'Excellence en Soins Colorectaux, COCO, Colorectal Center of Excellence. So they've been working with Indigenous research methodologies and lived experiences at the Center for Excellence for Colorectal Care. They have a patient community partnership program. I won't be able to give much details about this aspect as I haven't collaborated with Dr. Wissanji on this aspect. But so they currently have 2 patient partners and families involved in the clinical research and a community research guidance group with Cree community patients from the James Bay. So that's a bit of a theoretical background, a few frameworks, some analogies that we've discussed in terms of what it means to engage patient partners in research. Now we'll switch gears a little bit and talk about my experience and that of my team with the Marvin and Champ health chatbots. So I'm fortunate that Dr. Bertrand Leboucher, founder of the Marvin chatbots, and Dr. Yan Chaoma, postdoc now in our lab, who's the brain behind the Marvin chatbots, are here in the audience, and please feel free to pitch in given your rich experience. So we'll talk a little bit about how in the field of health AI can patient engagement provide a value. There's quite a few opportunities. And why does it matter? I mean, if you look at this review of health AI research and the role of patient-reported outcomes compared to clinical trials that do not involve AI, well, AI research has been lagging behind. So compared to about a quarter of clinical trials that included as a primary trial endpoint a patient-reported outcome measure, less than 10% of AI-related trials included that as an endpoint. So on the left-hand side so the graph on the left-hand side, you see different specialties so in terms of health AI trials will include AI, PREMS, visual analog scales, or other usability measures. And in red, they're not using any of those. You can see there's some variability between specialties. And on the left-hand side, you're seeing that perhaps it's on the positive front, it's been recognized. This dates from 2023. So you're seeing that since 2018, the number of health AI trials integrating some form of prompts in their methodologies and their evaluation has increased, but it's still lagging clinical trials that do not include health AI. So something for our community involved in health AI research to keep in mind. So I mentioned the Marvin chatbots, which includes a growing family started for and with people living with HIV. That was the initial intent of the original Marvin chatbot, to support with the complex antiretroviral therapy that people living with HIV must adhere to every day in order to live fulfilling lives. And then it's evolved over the years into Marvin Pharma for community pharmacists on this front, so it's more provider-facing, treating conditions related to HIV. Marvina for women with breast cancer. And more recently, we're working on adapting Marvin into Champ, which is a pediatric version. So a pediatric health chatbot for acute infectious conditions, because it's something we see very frequently in the ER, and in many cases could benefit from empowerment of families through trustworthy information and education for self-management at home. So that's why we focused on those conditions. So Champ essentially aims to provide validated health information to help families manage their health information, their symptoms at home, ideally, or guide families to the right care. Perhaps ER is not the only alternative, although in some cases, given operational system-wide constraints, families are shunted to the ER. We're hoping to provide some additional tools to families here. Our study process for the CHAMP study, so an AI-enabled chatbot to assist the management of pediatric patients. We worked really hard to corner that acronym. We sometimes forget what it means. It's been a few years already. So the study process involves certainly a needs assessment that we've completed. We already have a co-construction committee. So that is part of our research team, longitudinal involvement, deep involvement of patient partners, a knowledge database creation, so curating different sources. And a lot of these sources will come from our patient partners, family partners. Hey, have you looked at this tool? Have you looked at that other one? Who, through their own networks, will be able to bring back really useful information, not to reinvent the wheel in terms of knowledge databases, because there's quite a few of them. Sometimes it's about parsing through them and being able to leverage some AI to summarize in a way that's palatable and interpretable by families. And the next steps will include accessibility and multilingual adaptation. We know that a lot of the families we care for at our institution face different barriers to access to care, including from a linguistic perspective. Then co-interpreting results with our patient partners and evaluating the impact of co-production, co-design throughout our project on the eventual tools and on the research process in itself. So there's a whole evaluation of partnership science involved to be able to provide more reproducible, shareable information with our partnership community and other communities who aim to include that in the research. So what does it look like? I'll go quickly over this slide because I know that Annie-Danielle will provide tips on keys for successful engagement. Just so you know, the American PCORI, so Patient-Centered Outcome Research Institute, has a nice infographic, and then you can click on each one of these and see how do I use that in real life. So talking about some keys, some foundational keys for a successful engagement in research. So representative involvement, early and ongoing engagement, dedicated funds, as we've touched on earlier with respect to Indigenous patient and community engagement, building capacity to work as a team, meaningful inclusion, and ongoing review and assessment of engagement, which I mentioned as part of our framework for CHAMP. For CHAMP itself, if you want to look at these posters to the QR code and share it within your networks, we'd love to have more participants. We're looking for teenagers, actually to have youth. That's an outer layer of complexity in pediatrics, involving patients with their own lived experiences into the research framework. So that's one of the ways that we're trying to engage youth through small groups, through co-construction activities. And the research team involved in CHAMP, I'm really proud of this slide because you see in green, we have patients and members of the public who are part of the team. In blue, you have methodological operational experts in the science of patient partnership. So you see that a big part of our team has that expertise at its core. And that's a very heterogeneous sets of experiences and expertises in patient partnership science, which helps the team move forward. But at the same time, because it's a very technology-heavy project involving AI, involving digital health implementation, we also need technical experts to be around the table, all collaborating with one another in real time, not as an after the fact. We have this tool. What do you think of it? We're building it together. So the computer denotes members of the team who are experts in either software engineering, health AI, computer science, so more technical disciplines. And really, it's about learning, again, how to speak as a team and how to speak together. That's an added difficulty in health AI research. You can see some of our early prototypes with the CHAMP chatbot would provide really lengthy responses. So some of the fairly obvious but important and really important insight that our patient partners provided was that it's too lengthy, especially if you have an urgent question. So very rapidly, we started talking about needing to identify an urgent triage early in the conversation to identify whether or not this is even the right tool for you, not waste time to, at the end of the day, realize that maybe this chatbot wasn't what you needed, but also balancing comprehensiveness and conciseness. So we might have some preconceived ideas of what that means. Families who experience that, especially with the young ones going to daycare, with fevers, with concerns, off hours, may have important perspectives to share as well. So Oh, this is a PDF. That's why it's not animating. So you can see in the back that there's different iteration of our chatbots, and some key focus areas now that we're working on based on longitudinal input from our group. And that's one of the advantages of having patient engagement throughout the developing life cycle in technology and AI research, is that you're not investing 2 years in the technology to at the end of the day realize that, oh, actually that wasn't the right target. Very quickly, after a couple of months of technological progress and changes, we can realize that, well, actually, we need to focus on some other areas. So some of the cues that we got was to add onboarding and user orientation, making responses more accessible and structured, strengthening emergency identification and triage, once again, incorporating audiovisual aids for symptom clarification in addition to the text, tailoring responses to context and link to existing evidence, and also maintaining a professional tone and clear medical scope were some of the preferences that our users have voiced so far. This shows that it's a dynamic field when you're working with AI research. Our infrastructure and core architecture of the chatbot on the left, the early steps that Dr. Lussier, Dr. Mann, and their team started back in 2020 involved natural language processing in a way that was perhaps not as sophisticated as large language models that we have now. And now we're looking at it, integrating different agents into a multi-agentic workflow. So in a few years, this has changed quite a lot. But the objective that we have is to really have co-occurring technological and sociological involvement with our patient partners. So it's really doing all of this transition from a more static architecture to a more dynamic one with the patient voices throughout it, because there's a lot of key questions that need to be addressed throughout this process that can't wait a year or two for that to be tested clinically before we have patient and family input on it. In parallel, and I'll end shortly, Annie-Danielle, so that you can take it away with your own perspectives. In the emergency department, we've set up a council for Family Advisory Council for research, with the understanding that patient engagement and community engagement takes time. It requires an infrastructure. If you started from scratch, it's a worthwhile, if that's your context, if that's your reality, it's worthwhile effort. But the trickle-down effect of having an existing structure, we believe that can really help improve projects by bringing those voices more dynamically, more naturally into projects, and really lowering the bar for more researchers to use it into their practice. So that's the idea of a Family Advisory Council, which we based on other centers at Sick Kids, at Winnipeg Children's, at Saint Justine. They had similar approaches. So we tailored it to our own needs here at the Montreal Children's, specifically in the emergency department where I work and live sometimes. Wow, okay. I'll have to explore that one. I'm going back this evening, so I guess it's in my mind. Yeah. So on the left-hand side, that's a family-facing for recruitment. So we actually have 12 members on this council from different perspectives, including youth. So we have a 17-year-old, we have a 19-year-old who visited our ER with chronic surgical complex conditions. So she was in the ER quite frequently from a young age until later on before being transitioned to adult care pathways. And on the right-hand side is for clinicians. So saying, use a service. So we're still in the phase of changing the culture a little bit in the ED in terms of including those voices. So it takes reminders around academic half days. Hey, remember, we have this council. It's not a reflex from our fellows doing research, from our staff doing research, to include this. And eventually, the idea would also be to inform QI, to inform other care processes within the ER. But we're starting with research from a strategic standpoint to be able to also compensate families for their time and so on. We felt it was the right way. So for those of you who wish to integrate that to your clinical platforms, I think it would be a really nice model. And every time we meet with this group, I'm humbled by the generosity again and the quality of the inputs and also the networks. For example, the poster that I shared earlier, all of a sudden we have one mom who's also working in a network in the South Shore to which we had little access. Oh yeah, I'll share it within our social media group. You can come and join our youth working at our center or coming to interact with us at the center. Come and present your project. So many opportunities, completely unexpected. And once you have that pathway and that infrastructure set up, really it's a beautiful return on investment, I would say, afterwards, and makes it much easier for yourself and also your colleagues to benefit from that wisdom of lived experiences. Also, one of our PhD students, Jai Lin, has worked at a social pediatric center where I work at Garage à Musique with youth and co-authors actually on this position paper that was, or this commentary that was published in PLOS Digital Health on Healthy Futures Online, rights-based perspective on digital literacy and children. I'm not sure about you, but I have the impression that we're talking a lot about children and youth, about use of social media, when we don't always set the right example with our own phones, and they're kind of left out of the conversation. And this was extremely insightful, having perspectives for the youth. And one example I'll give is authors there said in one of her classes, the solution that they came up with to have better participation in the classroom and less focusing on the screens, which I'm sure many of us struggle with, was actually to come into the classroom with a pair of wide-legged jeans, lots of pockets. And she would say, I'm putting my phone in one of those pockets. I'll give it back to you in the class. And people, like the idea, felt it was a bit silly, a bit funny, came in, put the phones in her big pockets on her jeans, and they participated and had fun at their music class, and nobody was using their phone. So this was youth-led. It wasn't, we're going to impose this ban or that other ban. I mean, there's some value in those policies, but just remembering that youths are the experts of their lived conditions, their lived challenges. They might have really frugal innovation ideas to be able to tackle those challenges because they experience them day in, day out. So important to think about those voices. I'll stop here because I really want to have Annie-Danielle share some of her steps in research. So we'll switch over to Annie-Danielle. Yeah. Any questions as we do the transition slides? Questions, comments?
Just to say that it's very refreshing to see this and beautiful to see this approach. And of course, we'll see Annie-Danielle as well. It's a long stretch from using patient in your research proposal to have the checkpoint done and to say, yeah, they're not going to have a problem with this. And you put your little application to the SPOR and and you've got your patient partner set up. Or a lot of the sort of tokenism of getting some parent who is usually quiet and doesn't bother much and doesn't disturb anybody and is a bit of a shadowing presence, absolutely in that first stage of listening only, of involvement, and never caring or encouraging them to move on to the further steps, because then they would actually need to be dealt with and addressed. So thank you for the underground's realism and beautiful way you've actually done this.
I appreciate that, Dan. And it was really the purpose of the presentation was provide some tips on how to do this, because the time is now, right? It takes time, it takes effort, but it's worth it. And look around, we have great resources. I mentioned ChildBright, right? Here is a beautiful example. Dr. Pernier's lab also does fantastic initiatives in this realm. Dr. Leboucher's as well. So there's lots of people that do it right. And I think there's a lot of cross contamination, if you will, of best practices among us, or good practices in this realm. So a lot to learn from one another. So I'm glad that you're able to share, and I'd be very curious to hear about what you have as well. This was a beautiful segue onto Annie-Danielle's part of the talk, because I wasn't the one on this last round of funding. I wasn't the one who went to Annie-Danielle as a patient partner to put her name as a token. Maybe I was tokenized, Annie-Danielle, I'm not sure. You'll tell me. But you came to me and said, hey, I'm going to be PI on this project. And would you be co-PI with me on a project? But I won't reveal the end result. I'll let you do that. So beautiful transition to her part. Any other questions or comments before we transition? Perfect. Annie-Danielle, please take it away.
Is the audio working fine?
Yeah, we can hear you.
Thank you. So I'll be talking of my journey as a patient partner. So I'm going to go back a bit from where Esli was starting to talk about. Since what I do as a patient partner is the topic of this talk, I won't go over this in detail, but I don't have any financial conflict of interest to disclose. I'll talk more precisely about my health journey, awareness raising, patient partnership with examples, and what I think are keys to a successful partnership. I won't go over my complete medical history. Even a quick overview takes a lot of time, as you can imagine looking at this figure. I'll concentrate on a few key moments so you see where I'm coming from. As a kid and until the end of high school, I would have told you I was healthy, even with the frequent injuries like sprained ankles and the frequent infections, ear infections, pharyngitis, bronchitis, pretty much all the itises. In Cégep and university, I had less infections, but more injuries. I had to adapt or stop some activities like dancing, which was my passion. I started having difficulty with some movements and have more and more pain. Still, I was a bit hyperactive. I was studying full time, involved in extracurricular activities, I had a full social life and a part-time job. Actually, I was working at St. Justin's Hospital in the ER in part. So at 24, I hit a wall. I caught an infection in the ER and I never recovered. I developed a post-viral syndrome similar to what we see today with long COVID. I couldn't function or live alone, mostly because I was fainting regularly. I had crushing fatigue and lots of pain. I had to go live with my parents again, was socially isolated. I lost all my friends except two. I had to file for bankruptcy and disability welfare, pardon me, mostly because I didn't have a diagnosis. So from 24 to 30, I was on what we call a diagnosis odyssey. I was looking for answers, but mostly being told it was all in my head. I experienced problematic situations and attitudes from healthcare professionals, like rolling their eyes when I was talking about my symptoms or putting documentation that I brought in the recycling bin in front of me. Today, instead of it's all in your head, this is the picture. I have three main diagnoses, about 30 diagnosed comorbidities. I see regularly a dozen specialists like cardiology, neurology, GI, endocrinology, and more. And I have to take 15 meds or so daily, including to keep me alive, and about as much as 15, depending on my needs. I had no choice but to find information online and take my health into my own hands. I got the Ehlers-Danlos syndrome diagnosis because I learned about it and asked for a referral. I got the autoimmune polyendocrinopathy and autoinflammatory disease diagnoses because I insisted for investigations in the hopes of doing better or to avoid deterioration. With a rare disease, it's often vital to be informed. When I said I found information online, you might have thought as in this meme. Don't confuse a Google search with my years in medical school. To which patients like me might be able to reply, don't confuse that 1-hour lecture or one article you had on my condition with my decades of living with it. I say looked online, but it doesn't mean I did a quick Google search or watched 2 YouTube videos. In my case, it means doing online research, for example, on patient associations or university hospitals' websites, reading scientific articles, attending webinars and conferences. I think I have more CME credits, if I could get them, than some of my doctors. And of course, learning from other patients, from forums or support groups. By contrast, I once had a doctor argue with me about symptoms that couldn't possibly link to Ehlers-Danlos, while I could see the EDS Wikipedia page on their computer. It's important to note that even if something is not up to date or in the textbook, it might be my reality. We must not forget that what's in the textbooks is usually what's common, while we are individuals. I never fit with the expected clinical presentation, among other reasons because of the impact my conditions have on one another. When we are expert patients, we want others to understand as well. This often means what I call informal awareness raising. It can be educating a healthcare professional, like explaining why I take this medication or what's involved in a particular diagnosis. It can be answering questions at the grocery store. I soon developed an elevator pitch, a quick way to explain my situation. For example, with questions about mobility aids or braces, I'd say I have a genetic condition that affects all the soft tissue in my body, like skin and ligaments, so I injure myself easily. But sometimes we want to go further, which I call formal awareness raising. I created a website, Ma Vie de Zèbre, in 2013 to give information on rare disease in French in the Quebec context, because during my diagnosis odyssey, I was looking for information and could barely find anything at all, even less in French. And when I did find some things in French, it was from Europe, so from Belgium or France. I said to myself, even if I help just one person, it'll have been worth it to do the website. It's been 13 years, and the website had over 250,000 visits so far from all continents. I don't update the blog as often now because I'm more active on social media and as a patient partner. I've done collaborations with patient associations. For example, I created a text-based game for the website that was adapted in France. I was published in an American book in 2021. It's called Chronically Empowered. And I've been published in the Experience magazine, which is focused on partnership, a few times. I'm a content creator with raredisease.net. I've given numerous media interviews, wrote a few op-eds, and more. During my diagnosis odyssey and since the diagnosis, I learned the importance of patient partnership in care, especially with rare or poorly understood diseases. So what is it exactly? Well, as Esli showed earlier, the Montreal model says that the patient is a member of the team, just like a nurse, a nutritionist, or a doctor. It's recognizing the complementarity of our knowledge and working in collaboration. To note, it is not giving in to all patients' asks, even the outlandish, but it is recognizing that patient experiences and knowledge is valid. I'm talking about this because I don't think you can become a patient partner in research if you're not or haven't tried to be a partner in your own care. I get asked what's the difference between the Montreal model of patient partnership and the patient-centered approach. Esli told a bit about it, but this is the best illustration I've seen. Being in the center isn't always the best. It's very well to be an expert patient, but if I'm not listened to, I'm vulnerable and powerless. After one particularly dangerous ER visit in 2019, I was seeing one of my specialists a few days later, a scheduled appointment, and I asked him what I could do. I didn't want to make a formal complaint. I knew it wasn't one nurse or one doctor's problem. I wanted to raise awareness. He referred me to the patient partner office of the Faculty of Medicine of Université de Montréal. They showed me this illustration in my orientation. My mind was blown. I had no idea all these different ways to be involved existed. And now I've played almost all of these roles. So you can be a partner in research, but also in education and at the organizational level. I'm a member of research teams, for instance, in bioethics. I participate in educational activities for healthcare students and healthcare professionals. I'm a member of committees like a selection committee, and often what we do is more of a combo than just one type, as I'll show later. Gradually, from one project and one connection to the next, I eventually had enough projects that I stopped working in editing and translation in 2021, and now work almost full-time as a patient partner. It was the first career change that was my choice and not forced by my health. Sadly, I often have to make difficult choices because I can't do it all. As a reminder, I'm a patient partner. So my health, as well as my finances, limit what I can do. I'm part of a dozen projects with multiple institutions, and I'll name a few examples to give an idea of the variety of what we can do as patient partners. I'm a member of the Educational Resource Working Group for the Canadian Immunocompromised Advocacy Network, a content creator for a long COVID course for primary care with Université de Sherbrooke and the FMOQ. I'm a member of the Navinat team au CHUM. That's Réseau National de Navigation Clinique pour les Maladies Rares. We aim to shorten the diagnosis delay by being a central point for referrals when rare disease is suspected. It just launched a few weeks ago. I'm a co-researcher for a project on hereditary connective tissue disorders with CRCHUM. I host or co-host partnership classes with the Faculty of Medicine of Université de Montréal, and I'm a member of McMaster Health Forum Citizen Panel, where we review knowledge synthesis products and write plain language summaries. Here is a ladder of citizen participation, which looks a bit like the matrix Esli showed earlier. It goes from simply informing or being consulted to being more involved in collaborating as a member of the team to being empowered in leadership roles. I started at the bottom, which is normal. by filling surveys or participating in focus groups. So basically giving information or my opinion. And I still do participate in that capacity from time to time. In 2021, things really started to pick up for me. It was my first research project, and it was with Esli. I joined DigiCit pretty early in the project. We co-created the survey, analyzed the results, co-developed the focus groups by developing the interview guide and recruitment strategy. I contributed to the manuscript. It was my first academic publication. When Esli developed CHAMP, he asked me and other DigiCit colleagues to join the team and to help put in place the Family Advisory Council he told you about. A few months after joining DigiCit, I joined the Bioethics Research PhD project about morally problematic situations experienced by adults living with rare disease in Quebec. We co-constructed a survey, analyzed the results, co-created the interview guide, and co-wrote multiple articles. One of those articles was an action plan to improve the situation. We had found in the study that most issues faced by patients with rare diseases was due to lack of awareness and knowledge of rare diseases. At about the same time, Quebec published in 2022 its first rare disease policy, and it was followed by an action plan in 2023, which also had awareness and education as its first priority. The project director, Professor Eric Racine at the RCM, offered us to work on an item of our action plan. I can't tell you how touched we were that he wanted to help us improve things. We decided to develop a workshop to raise awareness and find solutions together with healthcare workers. Eric gave us carte blanche, or almost. It was more than just collaboration. He guided us, but it's our project. I'm even the project coordinator. A patient partner colleague and I present the 60 minutes virtual participatory workshop to small groups of healthcare professionals like clinical teams or communities of practice. We give information about rare diseases, share the previous study results and patient testimonies, and have a discussion period with participants to brainstorm solution ideas. We are lucky to have the support of the M3S and Santé Québec. Back in 2021, we wouldn't even have dreamed of being able to do this. It's a good example of a combo of partnership roles doing both research and education. Following our collaboration in the rare disease workshop, Professor Racine brought me on as a co-researcher in his new research network on citizen knowledge and co-creative approaches, le RICI. I worked on the grant proposal, I'm a member of the governance board, and I was co-director of a working group last year. I invited Esli to join the network because I knew it was right up his alley. I had experienced how he truly worked in partnership. And last summer, while I was exchanging with Esli on AI and patient partnership, he asked if I wanted to lead my own research project on the topic. It's been months and I still can hardly believe it. I added my rare disease interest, contacted collaborators from other projects, and set out to write my first grant submission for Maria, a project on rare disease and AI. And we got a seed grant from the RICI to do a literature review and plan a major grant proposal. As a further show of confidence, Esli will also help financially with his research fund. So yes, maybe tokenism? I'm the co-principal investigator. I lead the project, but every step of the way, the decisions are made as a team. And it's a team with more people with lived experience than academic researchers or healthcare professionals, although many, like me, wear more than one hat. With La Force de Rare workshop team, we came up with a few keys to a successful patient partnership based on our experience, and a few concrete ways to achieve it. There's attitude. Be respectful and open, considerate, humble, and sincere. By that, I mean, it's not just checking a box, being sincerely interested in learning. Availability, to be emotionally available and allocate sufficient time. For example, it might take an individual meeting to deal with an issue. Remember that we are sharing experience, sometimes traumatic experience, and it's often draining and sensitive. On communication, it's important to be transparent. And by that, I also mean keeping everybody, including patient partners, in the loop, in the emails, not just when you think they are required. Listen, use clear language and avoid acronyms, and offer detailed instructions. In organization, it's important to set clear expectations. For example, it's very useful for us to know the time a task is expected to take. Sometimes if we go fast, we think we didn't do it right. And if it takes too long, we feel we are slow, but sometimes that's not the case at all. It's also important to prioritize and give enough time. Again, we are patient partners. So it's important to know what to do first if we can't do it all. And don't assume that patient partners want or can work evenings or weekends. A good structure is also important. As for helping participation, facilitate the meetings and remember that, making sure that patient partners feel safe to express themselves, especially if there are other healthcare workers around the table. Sometimes it can be intimidating. And use collaborative tools, be flexible, and offer compensation, as Esli mentioned. It's sometimes a sensitive topic. We don't like to bring it up because we don't want to seem like we don't want to do volunteer work or it's not important to us. But for me, being compensated means I can do more. I'd love to do just volunteer work, but I have bills to pay too. I also believe it's important to walk the walk because you can't say everyone at the table is equal if the patient partner is the only one without compensation. There are multiple tools to learn how to use or evaluate patient partnership. The Center of Excellence on Public and Patient Partnership, the CAPPP, and the Quebec Sport Unit, SSA Quebec mentioned earlier, are excellent resources in Quebec. To conclude, the impact on projects of having patient partners can be summed up by the fact that we bring a different point of view as patients, but also as who we are, the studies we did, our life and work experiences, and more. And as for the impact on me, well, when your life is turned upside down by illness, you often feel useless or guilty of not contributing more or as much as you'd like. Being a patient partner allows me to feel useful and to make a difference. Thank you for being here today, and a huge thank you to Esli for inviting me today, and in general for your trust and friendship.
Questions? Thank you. That was really interesting to hear from both of you. My name is Vivian Uka, in case you cannot see me, Gochi Vivian Uka. So I have a question just concerning what you just said about compensation for time. And I agree it's very important to, think about the time of patient partners and use it wisely and also compensate for it. My main concern is, as many of us know here, like it takes sometimes 3 CIHR grant trials to get the funding. So in cases where a researcher like me, I don't have funds yet, and I really want to work on a topic, and I want to involve patient partners from the beginning. So the conception of the idea, how can I compensate adequately for the time while we're still waiting for funds?
Annie-Danielle, do you want to take it, or should I start?
I would start by saying it's okay to explain that, and because I had the same problem as a PI. I had to think of how to do it, and it was to make sure people can get involved even if it's not paid right away. And what we're doing is planning for retroactive payment in the grant we are asking for. So that's a way to mitigate it.
Absolutely. And I think being transparent and thinking about how you're going to, in my experience, I don't think any of the patient partners were so adamant about the compensation piece. They value it though, because it shows your own valuing of their contributions. But there's many other ways to do that. At the same time, as Annie-Danielle said, people also have bills to pay, and that's displacing them from other important activities, perhaps professional activities. So it's a balance, but I think the transparency is one. But also at a systems level, I'm thinking sharing resources at core. Could we have a family advisory council for our research or patient? Because it's really, once you train a group of 10, 12 people, it takes a bit of upfront cost and time. But that group then really, it's a train the trainer model, right? It becomes so empowering to the group and to our community of researchers, where all of a sudden it's not tokenistic. You're really coming in. I'm noticing it in our ED Family Advisory Council, where people have very thoughtful questions, are able to share. We then regroup the comments, send it back to teams. In some cases, one person will kind of continue with a research collaboration, submit to CIHR as a patient partner. Perhaps a group can provide a letter of support as well. That makes it easier, especially at an early career stage, makes it feasible. But the money itself is maybe not the end game. It's really the recognition and thinking about outside the box. What are other ways of recognizing the importance of what is being shared? And that includes accountability, transparency. And as Annie-Danielle said, you're not going to incorporate all suggestions. Some might be excellent, but we might not have at that time the infrastructure, the capacity to integrate it. But recognizing that this was a good suggestion, this is why I'm not able to integrate it now or partially integrate it into the grant. That's important as well.
Annie-Danielle, just thank you so much. That was an incredible. I think that Esli sort of showed us how to walk the walk and not just talk the talk on patient partners, but you've shown me the universe of what can be done in terms of patient partners. And I mean, my dream when I grow up is going to be to have a PI, an NPA patient partner in my next grant. So thank you.
Thank you. We have a question on the Zoom by Lara. She asks if we have recommendations to how to bring variety of patient partners to the table, since some people are more at ease speaking about their experience than others. I'd say first, when you start a project and you want to include people, you can ask what they're more at ease with. Like, not everyone wants to contribute to a manuscript, for example, and it's the same thing about sharing experience. I think it's to offer other ways. So sometimes we have a meeting, but you can also accept emails or have an offer individual meeting if someone, maybe they want to share the experience, but they don't want to share it in front of other people, and that's fine. And so there are many different ways to adapt to the people you want to work with.
Absolutely. And I think being very intentional about what the concepts of equity, diversity, inclusion mean to us, mean to our project, mean to our team, being very deliberate about how can help operationalize them, right? And I'd be happy to share, for example, for the Family Advisory Council in the ED, we actually just shared a diversity survey within our group of 12 people to know what are some strengths in terms of representation of our group. Recognize it with 12 people, you will not represent a population of 9 million people in Quebec, right? So being intentional about that and also leveraging networks within our group saying, hey, actually for this specific project, we identify from our data on diversity in our group, from our formal conversations that we may need expertise or lived expertise in other areas. So engaging also with community partners, so community organizations can be a very powerful way, especially if your research involves vulnerable populations that are traditionally underrepresented in research for many important reasons that can be hard to tackle in one research project. So then partnering with community organizations can be a really good, effective way of doing that, but also going with humility. Remember some of the concepts that I mentioned earlier about the tent, the campement, is not going in, this is my agenda, but trying to understand with some humility, with some curiosity, what are some of the constraints, some of the desires and needs of your partner to engage in a mutually beneficial conversation. But that again takes a bit of time. That's why setting an infrastructure, perhaps some shared resources, pooled resources, can be a good way of benefiting collectively as a community of researchers from the precious insight that Annie-Danielle, this was an incredible story that you shared. It was just you're such a good presenter. So I think it really demonstrated nicely that the world is your oyster. But again, it does take some effort. It's totally worth it, however.
Bertrand Boucher, so thank you so much for both of you. It was really great. I have a question, because what we saw in our project is if really we want to do a real engagement at each step, is very time consuming and it's very difficult to find partners to do that. Even when we work with young people living with HIV, they are migrants, they don't have enough time to do that with us. We are full-time in research, not them. But at the same time, we want to be sure they will be involved. So my question is, possibly, I'm wondering if sometimes we can think about another approach is more the co-design approach. See, what is me? I learned that from the engineer we work with you and Show and the other. I think it's interesting because in the co-design approach, it's a bit different from co-construction because they decided to be involved in not in all steps of the project, but just they choose where they want to be involved. And after also they evaluate the project as a client. And I'm wondering if it could be interesting because it's nice on the slide, but daily life it's really time consuming, and sometimes otherwise we will not finish the project. So the engagement is here, but also we have a product, we have something to move. So I don't know what you think about it.
An excellent question as usual. Maybe Annie-Danielle, I'm sure you might have some insightful answers there. Do you want to take it or I'll try? Okay. It's a difficult question. I mean, part of it also refers to, some of the criticism. I mean, there's legitimate criticism about patient partnership science in terms of localization, in terms of professional patient partners, right? Where you end up seeing the same people being involved. So as you're trying to identify some of the blind spots that we mentioned and the opportunities that patient partnership science provides, you then end up creating an echo chamber of the same patient partners because of many reasons. It might be the only ones that are self-selecting to these communities, right? So that's a difficult challenge. I think it's still out there to be tackled. I think pointing back to what Annie said earlier, going with the diversity of approaches and being deliberate again about why do we need patient partnership? What am I trying to tackle? What are the benefits of patient partnership science for my project or for this specific phase of my project? And what is my capacity? Having a discussion with the group as well about the plan and being open to adapting that patient engagement plan depending on that interaction, I think is important. But one example is for us with DigiCit and now with Champ, we realize that some of the large group discussions, an hour and a half, it's a lot of time commitment from a busy parent, a busy youth. So we're doing sometimes drop-ins, and we'll do some ad hoc. Hey, so and so, you seem to really have an interest on that specific aspect of our chatbot. Would you be interested in participating in a drop-in? So providing some flexibility, I think, is one important key, and also recognizing that there's different concepts. You mentioned co-construction, co-design, that you can integrate at different phases of your project depending on where you're at and what you're trying to achieve. So the matrix of engagement I showed earlier doesn't mean that you always have to be in clinical decision maker or the decision maker, the empowered, the right-hand side. There's all these stages can be relevant at different steps of the project, right? They can each, and for different people, right? They can have the capacity to provide more information, to listen. Some others might have the capacity at a given time in their life to be on the more involved end of the engagement spectrum.
Annie-Danielle, Esli, thank you so much. I'd like to also acknowledge the contribution of Sonia Lussier to just the conceptualization of this talk, and Hussein Wissanji and Lee Hill. So thank you everyone for your contributions and for this thought-provoking talk. And hopefully we'll continue these conversations.
Thanks for organizing, Katya and Susan.
Thank you.
Merci beaucoup.
Danielle.
Merci.